Around the world in TCD news, what does your facility perform when you perform your TCD bubble studies? Do you include blood drawback? Do you insonate the basilar artery or extracranial ICA when there are no temporal windows? Do you still push the agitated saline with the probes in place over the temporal windows when there are no temporal windows? There are many variations. The guidelines that are recommended from Dr. Spencer for your Spencer shunt grade are to insonate your MCA and ACAs bilaterally with 3 or a small amount of blood drawback in your agitated saline mix, and count the bubbles in that M mode. You will do 2 sessions, 1 injection at rest, 1 injection with Valsalva. 9 cc's of saline, bacteriostatic is preferred, 1 cc of air, and as we said, 3 drops of blood or a half cc of blood drawback is recommended as well. If the extracranial ICA or basilar artery are insonated instead, this can be performed, obviously, and bubbles can be found. However, using the Spencer shunt grade in reporting this exam is not recommended. Allowing reporting verbiage to change to showing positive or negative results without using the verbiage of Spencer shunt grade would be recommended. Moving along to your TCD vasomotor reserve exams, your breath holding index. There are reports of exams being performed for migraine. What does your facility perform? Do you do a TCD vasomotor reserve breath holding index on your migraine patients? And what is the cutoff threshold? Do you say a breath holding index greater than 1.1 is elevated, is suggestive of migraine? Do you say a decreased breath holding index is suggestive of migraine? Does your lab incorporate the migraine vascular index? This is doing your breath hold with your baseline before breath hold, your change in mean velocity with breath hold, and then doing some hyperventilation and seeing the change after the hyperventilation is performed. This is your migraine vascular index. Is this used, and how accurate does your facility find it? There are many different variations in performing TCD, and if we can do TCD for migraine, how can we improve this process? One other reminder to include in case you need another way to identify if you're accurately in your posterior cerebral artery versus your middle cerebral artery. When a patient closes their eyes, the mean velocity will decrease in the posterior cerebral artery. This is because the posterior cerebral artery supplies blood flow to the occipital lobe. In turn, the visual cortex is located in the occipital lobe. So when a patient has their eyes open, the mean velocity will be higher in the posterior cerebral artery. If you need a way to identify you are accurately in the PCA or posterior cerebral artery, have the patient open and close their eyes and see the decrease in the mean velocity with their eyes closed. That is all we have for today. Thank you for your time and attention.